perfectly happy teaching, doing, etc., until I got a couple of bum hips. This is 19.
I remember your story, because I read your story in one of your books.
Yeah.
Yes.
So, anyway, it was absolutely true. When I was lying on the gurney waiting to have my hips done, I couldn't wait. I just couldn't wait to have it. Come on, guys, hurry up. I'm in the big place. But I realized that that's not what most patients felt. That's the first thing. That was one of the first impulses that sent me towards writing a book about the subject of joint replacement. And then I realized that a lot of patients were either fearful or even antagonistic at times, with a lot of, suing of doctors that didn't give them an A number one joint, etc.
Right.
And then came the whole business of the metal on metal, which put manufacturers at a conflicting, posture with patients. And the more this stuff came out, I realized the problem is communication. It's information. And there's a lot of information out, but the question is it relevant? Does it reach? Does it teach? Does it get to the right person? Does it do what you want it to do? So I started in with this point of view. And the books that I wrote are none of them, they're their books. They're not meant for that. They're meant to make the patient, as much as possible, a junior partner in his own procedure, however major and however technical. And the only way to do this is to get him information about exactly what goes on when, from start to finish. And that's why these books developed. So I wrote the first book, which was about hips, which I'm going to do a second edition to because some of the aftercare has changed from when I wrote. I wrote it in, 2010. Then I wrote a book I wrote just recently. It's called Caregiver's Handbook to knee and hip surgery, because I realized that unlike emergency surgery, elective surgery, in this particular case, joint replacement, is elective, which means you don't have to have it, you won't die or bleed out. And it wasn't ever a solo, unlike emergency stuff. It is not a solo procedure. There's always someone who goes through the procedure with the patient. It could be a wife, it could be a spouse, it could be a partner, it could be a child, it could be anybody, but it's not a solo event. And then I thought, when I've ever had someone like that who's a second set of ears and eyes, I've always used them. I've used them to explain anything that they want doing, to reassure the patient, to go through it, and to take up all the slack that a potential patient may present, including, pre-fixing their home up, et cetera, et cetera. That's why I wrote the most recent book. And because I really do believe that caregivers can be an enormous help to a surgeon, enormous. A partner, a making their life much easier and so forth. And then I wrote all of this.
So let's talk about the Caregiver book right now. All right?
Okay, great.
Based on what you've written about and what the book has, what are some of the challenges that a caregiver of someone with joint replacement has?
Okay. First, a second set of eyes and ears is probably an enormous function there, because by and large a patient gets told you need a total hip, you need a total knee. And the listening ears, as Judge Judy says, go. They just only hear a part of things. The stuff that the information is given sometimes is forgotten. They're then given a slip of some kind, of pamphlet of some kind, but really may not read it. But if there's a second person involved in listening to what needs to happen and when it needs to happen and how it needs to happen, it happens. And it happens in a very good way for both the surgeon and the patient. So that's part of what goes into this thing. The second thing is it's a book meant to bring the caregiver and the patient together to the problem and solving the problem of whatever joint is wrong. The book can be read by the patient or can be read by the caregiver. It doesn't make any difference, but best it's read together. The next thing is you really are creating, in a situation of need for a patient who may need a joint replacement, an enabler, someone who can deal with the insurance papers, someone who can deal with getting their home prepared and ready, someone who gets someone to get their pet walked. I mean, it's that kind of very practical what a caregiver can do. And even in hospital, they can find out, who the nurse on the floor is in charge of things if something needs to be done, where the panic button is on a bed. I mean, it's very simple stuff like that. And that's why I wrote this. And the interesting thing is the response to this book, because I wasn't sure how it would go, has been very good.
So let me ask you.
Yeah, go ahead.
Let's take a situation where the caregiver is not necessarily the health proxy, okay? So I want you to distinguish for the readers here the difference between someone who is the health proxy and someone who you're calling the caregiver. Because a caregiver could be a neighbor, could be someone designated. So let's make a distinction between the health proxy and a caregiver.
Okay. The caregiver doesn't have to be the health proxy person at all. Maybe someone very different. Its function is different. Its function is much broader, much more from start to finish kind of thing, much more informational, much more in the patient communication area rather than making vital decisions of that sort. It may be the same person, but the chances are that's going to be a wife, a parent, and so forth. It may not be the same person at all.
Right. And if do you recommend multiple people in a family reading a book like this, besides just...
No, they can read it, but there should be one designated person. And sometimes the most close person to the patient is not the ideal caregiver. They're too emotionally involved in the procedure. But one person should be elected as a caregiver, and then a second person can be chosen in case for some reason the caregiver is not available at a given time when something may be needed. But it's totally different than a health proxy.
Sure. Now, there is a lot of movement now, certainly in the last year, to push joint replacement out of the hospital earlier and also to do outpatient joint replacement. What do you think how important is the caregiver in this outpatient joint replacement setting?
Well, very. There's a difference between informing a patient and getting them information which is going to be very helpful in their understanding and going along with the instructions they're given, and making them responsible to observe anything that might happen in the early post-op period, any complication which can be developed, the early signs of it and so forth, even the late signs of it.
Well, yeah. So let me split that for you for a second, because clearly there are a number of people who are pushing this for a small subset. I'm not referring to everyone being pushed out. I'm referring to like the 10, 15% of patients who possibly are available for enhanced recovery, right? Mm-hmm. But you have a very good point. Even though ideally a responsible surgeon would not discharge someone before their time, we will, for the sake of this question, agree that at times this push to enhance discharge, faster discharge, possibly puts greater pressure on the caregiver. So the question I have for you is, given the fact that the world is getting people out of the hospital earlier, what do you think in your opinion, the extra challenges that gives to the caregiver. And I'll compare that differently with someone who went to a rehab hospital for 2 weeks, got discharged, and you're the caregiver, right? Versus the person who went home after 3 days. What do you think of those two different worlds, the challenge for the caregiver?
I think they're night and day. First situation, you're hoping to educate a caregiver who's not going to develop these things, but can observe and watch. You're trying to educate him to be very alert for certain kinds of major post-surgical early complications, which don't develop in the hospital, but after 48, 60 hours, say, may develop.
Now, do you discuss those in this book?
I'm sorry?
Do you discuss those specific things in the book?
Yeah.
Okay, so what are some of the specific things you discuss in the book? Like, what are some of the diseases that you told them to look out for?
Development of infection, which can happen on a slow basis rather than fast basis, and particularly as the wounds are being closed much more quickly and without drainage in many instances. So an infection can be indolent and begin to show itself only after, let's say, 60, 72 hours. That can happen. The issue of emboli or thrombi may or may not be adequately taken care of by the anticoagulant, which is administered for post-op use and home care use. And the caregiver would be the first person to say, you look a little red, that calf looks a little red to me, or you look like you've been rubbing it. Are you in pain in your calf at all? That kind of thing is precisely what can be done about this. But the caregiver can do this kind of thing where the patient is involved in, let's see, which foot do they tell me to put with the crutch first, go on the first and the second? And when do I give the crutches? How many times a day am I supposed to do this exercise? Their concern is much more personal, physically personal, whereas the caregiver has some objectivity and can watch what's going on and is being told what to watch for, what are some of the problems to watch for once you get a patient home.
What kind of stresses and for how long will they last for the caregiver?
I'd like to see a caregiver go through the postoperative period until the patient is really independent, almost independent. Always lesser care. In the beginning, more care. And slowly, as the patient is observed to be able to take responsibility and to be more independent and get free of lateral support and so forth, slowly to withdraw. A patient who goes home, let us say even a young person who's having a knee replacement and has a large dog at home, you don't want them out with a large dog on lead for, a week or two or three until you're sure they're steady and strong enough to handle it. Someone goes into a hospital and has, let's say, a shift drive car, or even without a shift drive car. The caregiver wants to observe this and really do this work often for them until they're dead sure that they're able to do this. For my patients, after a hip replacement, I didn't want them to try to drive for at least 4 to 6 weeks. They're giving patients more permission earlier, but I really don't think it's a great idea if they have to come to a sudden stop or make a sudden change or something. So the caregiver fits into all that kind of stuff. It also, protects the patient from a lot of misinformation or misunderstanding about how to handle themselves in the postoperative period.
Now, do you recommend
you're not supposed to do something? So there's
do you recommend the caregiver sitting down with the patient beforehand and developing? What's the nature of that process of developing a comprehensive checklist? Do you have examples of sort of sample checklists the caregiver?
Yes, absolutely. Absolutely. I believe in writing things down. both for the caregiver and the patient. They can both look at this. And as they, for example, as they talk to, actually there's some charts in the book which they can use. But in addition, which, as they sit down and talk to the surgeon and the anesthesiologist and the rehab people, they absolutely should be taking notes. While the patient may be doing some of this, the caregiver can be recording some of the stuff that should be watched for, attempted to do, etc. Suggested, look at the schedule before you do this. There's a whole bunch of charts that have to do with remembering people involved, appointments involved, landmarks, what to do before surgery, a healthy health history form, medications, to be sure medications are taken in a timely fashion, all kinds of things like that. And that's caregiver stuff.
Well, let me ask you a question. How can a caregiver get into trouble in the across the board? And I'll divide it into three areas, okay? Area one will be in their relationship with the patient. Area two will be in their relationship with the doctor and the hospital, and then separately, maybe legal and medical legal trouble. So let's talk about how can a caregiver get into trouble with the relationship with their patient?
They can become overbossy and overprotective, as opposed to more observative and protective of the patient. And the patient can get to the point where they think, wait a minute, I don't need to be told this. I don't need to be. I know these things. So that kind of thing can happen. Mm-hmm. But it's not as important as a bad relationship or a poor relationship due to lack of information developing between a physician and the patient, right, or the caregiver and the patient. Now, a caregiver cannot go in with an attitude of, tell me, I'm the boss here. Absolutely wrong. That's not their role. That is not their role. They are a caregiver, not a decision maker. And that is made clear, and their role is made clear in the book. And also, there are issues that have to do with who you choose as a caregiver. I mean, you want someone who, for example, can stand hospital smells, and if need be, is strong enough to lift a patient up off a chair, who is not so involved with them emotionally that they don't see the issues clearly, the physical issues that have to be dealt with as they may arrive. So all that is true. Medical legally, I don't know that a caregiver could be sued. I can't think of how they could be, even if they give wrong advice, and even if they're on the wrong team and they miss stuff and all the things they're not supposed to do. But I still can't see that they could be sued legally.
How about the caregiver's relationship with the doctors and hospital? Can you give some advice to the challenges that the caregiver will have in communicating with the doctors, the nurses, the office, the medical people? I'm not talking about the finance and insurance. Specifically, all the what are the challenges that they're going to face?
What they want to do is, if they have never been a really great listener and a taker down of the information given, they must become this. They cannot substitute their judgment for what's happening in a hospital or what the doctor the surgeon is offering to do for the patient. That's not what their role is, and they're not to interfere with that. If they see something, as can happen inadvertently in a hospital or in a medication situation, which is obviously going very wrong, their role then is to talk to the responsible people in a very objective and quiet way, as opposed to hopping up and down. And it works out very well if they introduce themselves to the people involved, explain why they're there, ask how they can be of help, not come in with I'm going to be the lion tamer here, and I will make any kind of, absolutely they're not decision makers or anything like that. but rather I want to be able to make sure the patient understands what you're telling him, her to do, when they're to do, and when not to do. That attitude of a listening and therefore conveying accurate information is really important.
You know, as a joint replacement surgeon, and I have practiced in multiple different environments. I practiced in a managed care type environment like Kaiser. I practiced in a boutique kind of joint replacement practice. I practiced in an urban setting, okay? And one thing that was very clear or a challenge to me as a surgeon was who's who in relationship with the patient. You know, you go to the bedside, you see the caring neighbor, the caring daughter, the 5 caring sons, the 6 cousins, and you're not sure who's who. Are you pushing possibly for the concept of someone who is formally discussed with the doctor, this is my caregiver, you know, like, you see what I'm saying? Like someone says, this is my brother, this is my son, this is my 3 daughters, but this
Wonderful. Glad to meet them. Aren't you charming? Who is the one person I'm going to be talking with? I'm not going to be talking with 6 people because it's like the telephone game. It never gets right. So the caregiver is that one person, that one conduit who can be relied on consistently without saying, I don't care about the rest of your family. That's, of course you care about, as a surgeon, the rest of the family, but you're not going to be dealing with 16 people. When that happens, it's a disaster. It's an absolute disaster.
Let me ask some rapid-fire questions, okay? And Judge, it's your short answer to the following question, okay?
Right.
You are called up on the phone, and you are asked to be the caregiver, okay?
Yep.
What are a couple of the questions you think you would then say before you said yes or no? You give me like 3 things you'd want to know. I'm being called up to be the caregiver. What are 3 things I want to know? You know.
1, do I have the time to do it? Because it's a pretty demanding, time-wise, it's a pretty demanding function. Do I have the time in the next 6 weeks or so to make this person the focus of my care? 2, am I able to handle medical matters in an objective way? In other words, I have some feeling of not, again, hospital smells, sights, and sounds. Am I able to handle that kind of thing? Am I able to handle a sick or relatively sick post-surgical patient or limited? Let me think, what else?
What about traveling? Will I have a lot of driving I would have to do, like picking up equipment?
Exactly. Am I going to be available to drive, to get someone to walk the puppy dog if no one else is, to prepare meals if no one is else there to do it, etc.? Do I have the time and the ability to do these very simple physical things? And last but not least, am I diplomatic enough to deal coolly and rationally with the medical personnel who deal with my patient and the patient's family?
All right. Now here's another scenario. Let's assume you're the caregiver, but you're a close relative. Let's just say it's a sister or a child, but not living with them. You get a call at 3 o'clock in the afternoon. I don't feel well. My leg feels painful and swollen. What do you? And they're very confused. So let's just say the patient nervous and not sure what to do. What advice would the caregiver give?
First of all, they get their body over to actually see and touch and be with the patient. First thing. Second thing is, if there's any question that they're dealing with a serious postoperative complication, they're immediately going to contact the surgeon and or be sent to a hospital emergency room. But the first thing is to get over to see the patient, reassure the patient or not reassure the patient, observe what's happening, and make a rational decision based on what they're observing and the way they've been educated, a lot of which is in this book about exactly how to look for post-op complications.
So tell me a little specifics about the book. Where does someone buy it? What's its full name? Where does someone buy it? And how much does it cost?
Okay, it's called The Caregiver's Hip and Knee Surgery Handbook. One can get it online at Amazon, and it can be a print book or it can be downloaded, either way. The price of the book, damn if I know, I think it's under $10.
Now, some surgeons will be reading this. Are there bulk discounts for the book if they were going to buy a couple of hundred and buy them for their
Yes,
patients?
you have only to ask me, and I would be delighted to give a volume discount.
How do people contact you?
I'm on I have an email, which is mehechtmd@comcast.net.
All right. Well, this has been a really nice interview, and I'd like to thank you very much.
It's my pleasure. Let me know what comes out of it, and if I can be of any further help or information for you, please don't hesitate.